The residents, mostly elderly, took this opportunity for free medical services. This outreach is done in remote rural areas where there is shortage of doctors. Screening and other services were provided.
We came to this area for primary health outreach, where we focus mostly on the chronic conditions like diabetes, hypertension, for the rural communities. And we come to these areas where there are no doctors visiting these rural areas. We were approached by the unemployed post-concept doctors so that can we host them while they are still waiting at home or sitting at home for their job opportunities.
Unemployed doctors have urged the government to employ them as there is still shortage of doctors.
We are facing a very difficult time, very unusual time for a doctor to be unemployed. So we had this vision as a group that no, what if we can use the time now to go and reach out to our communities and as a form of a giving back. Because I mean there is a shortage. There is a lot of people that need our services and we are sitting at home. We didn't want to nurse our depressions, we didn't want to nurse our stresses, we just wanted to have something to give to the community and also relieve the pressure that our colleagues are having in the current moment.
The residents have welcomed the services offered to them.
These doctors did not make us pay for their services. We were treated very well. We usually pay for this kind of services. They treated us very well.
The doctors did a good job for coming here to help the people in the communities because they made things easier for the people to come here. It is less costly or no cost at all because they'll just take a walk, most of them, to come and see the doctors. Because going to town, it's very expensive for them. And secondly, in the clinics, the doctors are not always there.
While treatment has not been available, referral letters were given to patients. Luandile Mbulali, Libote in the Eastern Cape.
Conversation now with Mawabo Ntulana. A very good evening to you. He's Inganga Group CEO. Thank you so much for speaking to us.
Thanks so much for having us at this one.
Just tell us a little bit more about your organization first before we get to how you came to bring it to this particular area and the resources you brought with it.
Yes, so Inganga started in 2016, focusing primarily on the primary health, where we do screening of chronic conditions and correcting where there's a need of correcting the medication. We focus mostly to the areas where there are no doctors going there, like the one we had yesterday at Nyandeni. We've been having these outreaches working with the Department of Health most of the time. Then this weekend we were approached by the unemployed post-concept doctors who wanted to go and assist in the areas that we've been assisting them. And some of these doctors that we're with, they've been attending during their internship and their community service years. They've been attending the outreaches with us.
So basically, is this done on a voluntary service? I hear you say you're working with the health department, but is this a group of individuals who are doing CSI work?
Yes, it's done on a voluntary service. We do, unfortunately, at the organization have to transport these doctors, organize accommodation for them, and also catering. But sometimes the community, the local communities, they do assist us when we visit them with the catering.
What can you share with us about the state of primary health care in this particular area and some of the major challenges that communities face?
The major challenge in that community that we were with yesterday is the review of their chronic treatment. That is diabetes and hypertension. And we know that this leads to stroke, the hypertension mostly, and the diabetes leads to amputation of the legs with these patients. And then after someone gets amputated in that kind of environment, they are unable to use wheelchair. So it keeps on the chain of events that complicates their lives. Some of the patients that we saw, they had the blindness secondary to cataracts. And there is no screening at all for those conditions in those communities. So hence we always go there, and we would like to go there mostly.
You mentioned diabetes and hypertension, but my understanding is that one of the biggest challenges there as well is TB as well as HIV. Is there any integrated services in that respect? And Eastern Cape itself having high levels of inequality and TB being associated with poverty, just how widespread is this problem?
There is a lot of TB in rural communities also. As an organization, we always seek to use the mobile chest X-ray where we screen for TB. Yesterday, unfortunately, we didn't have that resource because of the restrictions and the time frame we had to prepare for this outreach with these unemployed doctors. But we did screen, we did suggest to the patients that clinically we suspected them to have TB, so that they can go to the local clinic with our referral letters where they can do the testing for both conditions, the HIV and the TB. But the one that was easy for us to manage yesterday, it was the hypertension and diabetes, because we did bring those machines with us.
I'm just wondering, from a sustainability point of view, integrated chronic disease management, as we mentioned, issues of poverty, and we've seen for years stockouts being a problem. Do you feel like at some point it would feel like just a drop in the ocean, the work that you're doing, albeit important and much needed?
It is a bit of a drop in the ocean, I'll be honest with that. But I believe with assistance of the private sector in this regard, we can go a long way. For instance, yesterday we had more than 30 doctors. Some of them I can see on the video, they are doing blood pressures, they're doing blood sugars, of which those are the procedures most of the time are done by the nurses. Then the patients, they come to see us with those procedures already done. But because we were the only ones who were working yesterday, so we had to do those things. But we saw all the patients that were there.
Is there data that you work with that can be passed on, particularly for community healthcare services? And I don't know if there are networks that could help continue the work that you're doing. Immune deficiency being something that's not easy to handle when you're dealing with some of the diseases that you mentioned.
The complexity in these areas, for immune deficiency conditions, those patients, they need support, the family support. And mostly there is a lot of old people in these communities. So if we stabilize the old community, the old population, they will be able to take care of the younger generation that is mostly affected by the immunodeficiency conditions, including TB. So the more we do these kind of outreaches, and the more we have a sustainable relationship with the rural communities where we can go back, because to go once in a community, it doesn't do enough justice. So we have to keep going back to those, so that it can be a long-lasting, the basic blood pressure check. We prevent the grandmother of a child who's HIV or who was born by HIV positive mother. And now the child is living with the grandmother, and the child needs to take her or his chronic medication, the HIV treatment in this case. So if we take care of the grandmother, we're solving also the issue of the child that is born HIV positive.
But what are your infection control measures that you can take? I know this is, as you mentioned, on a voluntary basis. Even though you are working with the health department, are you finding ways of counseling, talking to communities, educating them so that this is not a self-perpetuating cycle?
We do a lot of health education, and we believe in health education, because the more people are aware of the conditions, the better it is. The communities, mostly that we, as I said, we started in 2016, that we have visited previously. When we go back there, it's not as bad as it was the first time we were there. So there's always one step at a time. So there is improvement for each and every community that we visit, even though we still believe we can do much better than we are doing at the moment.
Well, it certainly is a lot. A little goes a long way, as they say, and well done to you and those volunteers that you're working with. And here's to hoping that you get more support, whichever way you need it. Mawabo Ntsulano is Inganga Group CEO, speaking to us about the work that they're doing in that area in the Eastern Cape.